We will now be joined by Dr. Eric Hoffman to present recently reported updates from the phase 2 Vamorolone trial. Eric, take it away.
Thanks. Good afternoon. Can I have the next slide, please? And this is a disclaimer for Synthera. Next slide. So what I'll be talking about is a drug program we've worked on for the last 10, 12 years. The goal is to first understand why corticosteroids work so well, but as well to understand what causes their safety concerns or side effects. And we know that, and you've heard through this conference by a number of talks, that corticosteroids, both deflazacort and prednisone, improve strength, prolong ambulation, arm function, delays ventilator use, and delays scoliosis. But with that efficacy comes safety concerns. So weight gain, bone fragility, growth stunting, cushingoids, suppressed immunity, and mood and behavior changes. Now, some of these safety concerns themselves can exacerbate the disease. For example, I'm sure you've all heard of DMD patients who break a leg and that they lose ambulation because the leg breaks. And that bone fragility is a safety concern, a side effect of corticosteroids. So the goal of this program is to try to understand both efficacy and safety and separate them. See if we could come up with a drug that retained the efficacy but could lose some of the side effects or all. Next slide. So what we landed on, it was John McCall, Kanabrian Nagaraju, and myself, was a drug called Vamorolone, previously called VBP15. And the key is sort of in the northeast there, that H, where all other corticosteroids, there's 33 other approved corticosteroids like deflazacort and prednisone in clinical use worldwide. Fastest Nobel Prize ever awarded in 1950 for these corticosteroids, which are amazing drugs. We just changed that, they all have an O or oxygen there, and we changed it to a hydrogen. And what that does is we know now through lots of work with both academic labs and our own labs, is that changes how this drug interacts with its receptor, the corticoid receptor, and it changes the downstream properties. And what we're seeing is this separation of efficacy from safety concerns. So key difference is that Vamorolone is not a corticosteroid. Is first, it lacks that oxygen, unlike all the other corticosteroids, but it also reduces its effect on genes. So it doesn't turn on the genome, all the genes. Corticosteroids turn on about 10% of the genome by many published papers. We don't do much of that, and that seems more associated with safety concerns. You've also heard in this conference that eplerenone, spironolactone, are heart healthy. They're cardiac drugs, and you've heard that also they may improve skeletal muscle function. Well, they're mineralocorticoid and receptor antagonists. They bind to a different receptor than prednisone and deflazacort. We do the opposite to that. So we're an antagonist like eplerenone. So we have this new activity that makes us like eplerenone, spironolactone, at least in mouse studies. There's also HSD enzymes. These are 11 beta HSDs, which are in all our cells and tissue, and they carefully regulate whether prednisone or prednisolone is active or inactive. The same with deflazacort and cortisol that woke you up in the morning. We're not a substrate for those. So because they work on that oxygen and we don't have it. So those HSD enzymes are different. So the goal is then to see if we have in fact separated efficacy from safety concerns. Next slide. So we did our initial trials in Duchenne muscular dystrophy. I mean, this drug, if it is a replacement for corticosteroids, may be broadly used in arthritis and others, but this was all done by Duchenne scientists together with Duchenne foundations from the beginning. So we just focused on Duchenne. And we did a large first in-patient study. Many drugs you have to go in adults first, but here we went straight to Duchenne kids after a phase 1 study in adult volunteers, but in pediatric patients, Duchenne patients. And we did a large first in-patient study of 48 children, Duchenne children, 4 to 7 years of age that hadn't been treated with steroids. And we did first a 2-week on, 2-week off, which is a PK safety study. And we did a very broad dose range. We did a 24-fold dose range from 0.25 mg per kg, about a third of prednisone dose, up past 10 times prednisone dose. So a lot of different doses to really get a feeling for that safety efficacy balance. Then the patients were rolled onto a 6-month extension study at those same broad doses. And what we found, as you can see off to the right, is the 2 higher doses showed improvement on many of the outcomes, the motor outcomes, whereas the 2 lower doses didn't so much. So we were shooting for the 2 and 6 mg per kg going forward. So then those patients liked, and the families wanted to stay on Vamorolone. So it was a 2-year extension study. And 41 patients finished the whole 2 years, and they all dose escalated to the 2 and 6 mg per kg. Now that was recently published by Eddie Smith back in 2020. He was one of the speakers earlier in this meeting last fall, and that showed that the kids continued to improve past 6 months through 1.5 years on these outcome measures. And the improvement seems similar to corticosteroids. And there we started seeing better safety profiles. We didn't see the stunting of growth that you saw with corticosteroids. The bone biomarkers looked better. There were less physician-reported safety concerns like cushingoid or mood disturbances, but it was an open label study. And you always have to be hesitant about making any conclusions from an open label study where you don't have head-to-head comparisons against placebo or prednisone. Those patients have about a year ago finished the full 2.5 years of treatment. And Jean Ma in Calgary is writing up that data now and should submit a paper. But again, improvement relative to baseline, and again, loss of stunting of growth and scenes of bone morbidities in an open label study. So next slide. We wanted to go on to your sort of gold standard, placebo-controlled, double-blind registration study. The goal is, this is the type of trial that FDA and EMA and all regulators like to see in order to get the drug labeled or approved. So this was 121 children with DMD, boys, same 4 to 7-year-old, steroid naive. And they were enrolled in 11 countries at 33 sites. Many of the sites were the Synergy site groups. So you've heard almost many talks throughout this conference of the CINRG. That's a network of collaborating academic clinical trial sites that's worked together for 20 years. And the Synergy group has also led these Vamorolone trials. But we included a bunch of other sites as well in countries that like Greece and some others that weren't so experienced with clinical trials to be inclusive. So the patients were randomized into one of 4 doses, one of 4 groups. You see there in that treatment period 1, either the lower dose of Vamorolone 2.0, the higher dose 6.0, so that's about 3 times prednisone to almost 10 times prednisone. And then we had a prednisone arm as well, so a blinded comparison. And then we had placebo, so 25% on each. So that's the data I'll present today, which is this period 1. Now those patients, after they finished period 1, went on to all onto Vamorolone, including the placebo and the prednisone crossed over to Vamorolone. And those patients are just finishing up, so I won't show that today. I should mention that all the patients, both in the older trial and this trial, that finished the trials can go on to expanded access or compassionate use, and the vast majority have asked to do that. And so those programs are active in all 11 countries. Next slide. Now what you do is you have to, in a double-blind gold standard trial like this, set up your primary endpoint, your secondary endpoints, and your exploratory endpoints. And because we were doing 2 doses and also prednisone, we had to line these up and all agree with FDA and EMA how they're lined up. And you're only allowed to start at the top and see if you win on the first hand of cards before you go into the next one, before you go to the next, before the next. So our first primary endpoint was the higher dose of Vamorolone versus placebo, because we wanted to see efficacy versus placebo. And that was the primary outcome. And then if we win on that, we went to the secondary outcomes, which were then the lower dose versus placebo, 6-minute walk at both doses versus placebo, time to run walk, and then exploratory. We didn't line them up, but time to climb 4 stairs and North Star. And you've heard of many of these outcomes throughout the meeting. So now I'll show the results of this trial. Next slide. First, the randomization looked very nice. So this was all done by somebody overseas and everybody's double blind. So the patients were all randomized to these 4 groups, but the groups look very similar. Next slide. So this was our primary outcome. So this was the higher dose of Vamorolone in red versus placebo in gray. And there were about 28 kids per group. And you see the placebos are declining a bit in speed. So this is velocity, how quick they are. Whereas you see improvement with the 6 mg per kg. So this was highly statistically significant, 0.002. As you see there, you have to get less than 0.05. And so we hit our primary outcome. Next slide. If you just change that into seconds, how many seconds it takes the boy from lying on their back to standing up straight, you see that, again, the placebo boys are taking about half a second longer on average, whereas the boys on Vamorolone at the high dose are speeding up. So they're taking about a second less time. So about a second and a half or 1.7 seconds difference over 24 weeks. And this is similar to what we had seen in the previous open label study. Next slide. If you superimpose now the prednisone group on top of that, you see that Vamorolone is performing very similar to prednisone. Now here I want to make an important point. This prednisone in this study was 0.75 mg per kg per day, which is the recommended dose by the AAN, American Academy of Neurology, and published papers, standard of care. But an important thing is that the majority of patients don't get those doses that are recommended. You heard that from Craig McDonald in the placebo arms of published studies, where in fact they're getting about 75% of the recommended dose, both for prednisone and for deflazacort. That was also seen in the Synergy natural history study of 440 kids, about 25% reduction in the recommended dose. It's because everybody's trying to balance safety concerns and efficacy. So here, hopefully, if we can reduce the safety concerns, there'll be more flexibility with dosing and not so much of that struggle, so that it won't be underdosed necessarily. Next slide. Well, let's look at all the other outcomes. So what you see is we hit basically everything. So you see the primary, secondary, and exploratory all showed improvements relative to placebo at both the low dose and the high dose. And you see those p-values are all of them less than 0.05 by a lot, except the one there, time to run walk velocity at the lower dose, sort of just missed. So this is very compelling evidence that Vamorolone improves Duchenne kids and the p-value says quite impressively versus placebo, and all those were similar to prednisone effect. One thing I should note at this point is that you hear often in this young age of the honeymoon period. In fact, many trials, even I think the Sarepta gene therapy trial, showed improvement of these kids even without the gene therapy in this age range, the younger age range. Well, I think a lot of that's from steroids, because steroids, we know, as we showed in this trial as well, do a dramatic improvement of Duchenne boys. So from our trial, you see that if you don't give them steroids, they're in fact declining, not a lot, but declining over the 24 weeks. Next slide. So let's look at safety. Again, we're trying to separate efficacy and safety. Now, one thing you can do is just ask the physicians and the families to count up adverse events. And so we see hints that prednisone has higher adverse events than the 2 Vamorolone doses, but these are serious adverse events were very low. So there was only one serious treatment emergent adverse event leading to discontinuation of the study, and that was in the prednisone group. Next slide. Now, if we dig into adverse events a bit further and look at adverse events that are associated with corticosteroid use, and that's this pre-specified safety analysis off to the right, you see that the Vamorolone doses do seem to show less of these corticosteroid-like safety concerns reported by families and physicians, and that's significant. Next slide. So one of the things we had seen, as I mentioned earlier, in the 2.5-year study is that all the kids on Vamorolone grew normally. In fact, they grew a little faster. There seemed to be some catch-up growth than their peers. That's in marked contrast to all corticosteroids when given to a child at chronic doses stunt growth. So corticosteroids are well known to shut down bone remodeling and just halt growth, and that's part of probably making the bones more brittle as well. And so what we saw was we confirmed even in 24 weeks, this short time period, 6 months, that in fact, Vamorolone kids at the higher doses were actually catching up in growth. They're going, that's off to the left there, they're actually showing a mean of 4 percentile change. So they're catching up to their peers. Whereas we see the stunting of growth with prednisone that you also see with deflazacort and all corticosteroids. And off to the right is that 2.5-year treatment. And you see that normal growth is maintained over 2.5 years. Next slide. Now, this was new data of a head-to-head looking at bone biomarkers. So bone biomarkers, or bone remodeling biomarkers, have been used in nearly 500 clinical trials in all sorts of disorders and in 4,000 publications, because you can take a blood test and sort of look at these 3 protein biomarkers and see if bone is remodeling or not. There's sort of a surrogate marker for bone remodeling. Is bone growing or remodeling or shrinking? So what you see in the black bars is prednisone in this trial, this blinded trial, really shut down bone remodeling. Again, that's very consistent with what corticosteroids do to bone in anybody, adult or child. But you see in the placebo, the gray, they didn't do much change. But with Vamorolone, they actually increased in a number of instances. So that we have separated the bone morbidities. So we're not doing the changes in bone biomarkers. We're not seeing the changes in growth that you typically see with corticosteroids. Next slide. Weight gain is another concern. Now, with weight gain, it's not everyone on deflazacort or prednisone that gains a lot of weight, but some kids seem to be sensitive to it. So we basically see the same thing with Vamorolone. There's a subset of kids that seem to put on weight, and that weight gain is similar to prednisone, or a similar proportion of kids and similar amount of weight gain as prednisone. What we see in practice in the long-term safety study is that at the higher dose, if some physicians saw some weight gains, they can go to the lower dose, and that in some instances seem to help that. So again, you see even the lower dose group, there seems to be less weight gain than you see with prednisone, though that's not statistically significant. So it's about 5 to 26% of kids on Vamorolone started to see this weight gain. Next slide. So in summary, Vamorolone is being investigated as a first-in-class dissociative steroid with lower incidence of corticosteroid-associated adverse events. This double-blind 24-week study showed statistically significant and clinically relevant improvements across all the motor outcome measures we looked at across a broad dose range. So it's both a threefold dose range that hit in both efficacy and safety. Vamorolone did not adversely impact growth trajectory or biomarkers of bone health. Treatment was well tolerated with fewer physician-reported adverse events typically seen with corticosteroids at 24 weeks in a head-to-head with prednisone dose-dependent manner. Vamorolone is the first dissociative steroid. So to our knowledge, this is the first time that a drug has been successful in separating the efficacy from safety concerns of corticosteroids. And surprisingly, we found this over quite a broad dose range, a threefold dose range. And that will allow physicians to tailor treatment to the individual without losing efficacy, because we see significant efficacy at both dose ranges, both the low and high. Next slide. First, I'd like to thank all the foundations. PPMD has been a great supporter of this program. I should note that many of these foundation supports are under a venture philanthropy model. So when Vamorolone hopefully gets sold in the future, they'll get paid back plus 400%. So this is a shared risk, shared benefit business model, which we hope will bring funding back to the foundations. Also want to particularly call out a couple of these funders. The NIH NCATS gave us a trend grant, Therapeutics for Rare and Neglected Disease, and really did a huge amount in helping with the early drug development of Vamorolone. And then the clinical trials were supported by NIH NINDS, who is a major supporter of Duchenne research, and recently with a commercial registration pilot. And then also the European Commission, European Community provided a large grant to Newcastle University in support of the clinical trials for this. Next slide. And this is my last slide, just to thank the families first and foremost. We know this is a heavy lift to join these trials. We've gotten some feedback from families, and we hope our trials we try to keep visits down, and then COVID hit. And we're so grateful to the families and all the sites and the staff for doing the quick pivot during COVID. So we didn't lose a single patient in this trial while it was done during COVID. We didn't lose a single primary outcome because we worked with the families to do the time to stand using videos. And a shout out to Newcastle and Meredith James, who was critical in doing this very rapid COVID pivot to finish this trial in the time of COVID. And these are the sites and the physicians that worked with us, and the wonderful physicians at each of these academic clinical trial sites. And the study chairs, Michaela Guglieri at Newcastle and Paula Clemens at Pittsburgh. The Synergy Group, CINRG, spun off a coordinating center, which is TRINS LLC, and they ran these trials and did a wonderful job. You don't get p-values like that unless the trials run well. Camden Associates were medical and clinical monitors, and really we called them the adults in the room. They did a phenomenal job overseeing these studies. Summit Analytical for Statistics, and the operations, Jesse Gamsker, who's a master ceremonies, made sure the drug got to the right place and worked with all the sites. Thank you very much. Happy to take questions.
Thank you, Eric. I think we have time for just a few questions, quick questions. So we're, of course, tracking all of the sort of payer activity happening in the first approved therapies with Exondys, Amondys, Viltepso, et cetera. Those payer policies are requiring a 6-month steroid, corticosteroid use in patients to be used along with those therapies. Is there any concern? So you've talked about Vamorolone being a dissociative steroid. Do you think payers are going to allow for that as the steroid to be used with those exon skipping therapies? Sorry.
So your question is, will Vamorolone be an add-on to exon skipping and other therapies?
Yes. Well, payer policies, from what we're seeing in the access space, is the payers are requiring that patients are on steroids if they're going to get it covered for exon skipping therapies. So I was just curious of your take on what payers may think about if a patient, if this is approved, a patient is on Vamorolone, will that count to be included as an add-on with an exon skipping therapy? Well,
the intent of Vamorolone is to replace corticosteroid use. You'd never use corticosteroids and Vamorolone at the same time. Yeah. I mean, you can transition probably from one to the other, like even in our trial, patients transition from corticosteroids, prednisone, to Vamorolone. But we would be a different standard of care. So, I mean, we'd be, and you'd think that let's assume it's approved. I mean, the NDA will probably go in next year. Our feeling is that this data I showed you is sufficient for approval, but that obviously you have to go to the regulators and see if they agree. But once it is offered and labeled for Duchenne, then it all is that discussion with payers that you see with all these. Mm-hmm. Very different discussion for Europe and the US and others.
Yes.
Well.
Yeah. Okay.
Great. And then one really quick one that, of course, we had come in was, timeline for submission with both FDA and EMA.
Yeah, we're working together with Synthera on the submissions, and the anticipated date of NDA submission for FDA is first quarter next year, so about six, 8 months from now. And we're just getting all the pieces in place to do that.
Great. Well, thank you very much. We really appreciate you coming in and sharing some of that data with us here at conference.